Hi, my name is Takeshi Nishijima, or Nishi, Technical Officer for the Antimicrobial Resistance, AMR, at the WHO Regional Office for the Western Pacific. Dear distinguished guests, this is my regret that I cannot join you in person in Fiji, but thank you for this opportunity to present as a video presentation. So let me start. My number one message through this presentation is that AMR is part of the health security agenda, which causes significant public health threat. So AMR should not be a stand-alone program, but it should be the part of the health security agenda, and it should be considered as one of the health security agenda. So antimicrobial resistance, or AMR, occurs when bacteria, viruses, fungi, and parasites change over time and no longer respond to medicines, making infections harder to treat. There is a significant burden of AMR. In 2019, drug-resistant bacterial infections contributed to nearly 5 million deaths and were responsible for 1.3 million deaths globally. Also, the cost for AMR to national economies is estimated to reach US 3.4 trillion annually by 2030, with an estimate from the World Bank. These are the take-home messages from my end. Number one, again, AMR is part of health security, and then also a cross-cutting agenda, which is closely related to infection prevention control, for example, and then also mother and child care. And then AMR pathogen could be easily transported from one country to the others, just like COVID-19. So your countries cannot be safe unless other countries are also safe. Number two, stop overuse and misuse of antimicrobials to reduce emergence of drug resistance. We need to preserve effectiveness of available antibiotics. Number three, strengthening AMR surveillance at hospital level to use data to inform clinical practice to save lives. This is of particular importance because in each area, maybe the susceptibility pattern or which antibiotics is effective for which bacteria is different. So we need to obtain such data to ensure these antibiotics should work for this bacteria at this hospital. So this is the importance of the hospital level AMR surveillance. This is a table of contents I'm going to speak here today. So as you know, WHO have developed the Global Action Plan for AMR in 2015. And then each member states are requested to develop a national action plan by May 2017, following the structure of the Global Action Plan with 5 main pillars. Number 1 is awareness for AMR. Number 2 is surveillance and research. Number 3 is reducing the incidence of the infection, including IPC, or infection prevention and control. Number 4 is antimicrobial stewardship or optimization of the use of antimicrobial medicines. Number 5 is ensuring sustainable investment to fight AMR. So in our Western Pacific region, as of today, 21 out of 27 countries adopted and then also implementing national action plan, including Fiji. And then countries including China, Mongolia, and the Philippines are implementing the second national action plan. So the progress of the national action plan widely varies among the countries This is a data from 2022 TLAX, or the Global Survey on the Progress of the AMR National Action Plan. Here, in the graph on the left-hand side, you could see the progress of each country which responded to this survey for the progress of National Action Plan. Here, category E on the far right means the number of countries which have secured national budget for the implementation of the National Action Plan, which is only 10%. And then when you look at the category D, that's the countries which have placed monitoring and evaluation of GA National Action Plan. Category C is the countries which have been implementing National Action Plan. So the categories which are classified as C or D or E has been implementing National Action Plan. But again, the number of the countries which secured their own budget from their national budget, or the countries with monitoring and evaluation in place, are small. Just to show the importance of AMR in the global agenda, in 2020, 2 new AMR indicators were included or added to the Sustainable Development Goals indicators. Sustainable Development Goals, what we call SDGs. They are proportion of the bloodstream infection due to number 1, Escherichia coli, resistant to third-generation cephalosporin, and number 2, methicillin-resistant Staphylococcus aureus. And then the graph here from the GLASS WHO Global AMR Surveillance System shows the resistance rate for such two pathogens are higher in low and middle-income countries when we compare it with high-income countries. So now we are going to talk what's going on in our region. As we know, WHO Regional Office for the Western Pacific have a policy for the future towards the healthiest and safest region, where we have 4 thematic priorities. One of them is health security, including AMR. So our office regards AMR with one of the highest priorities. In 2019, member states in our region, of course including Fiji, have endorsed this framework for accelerating action to fight AMR in our region, with the operational shifts in the For the Future paper as a new way of working. The basic idea is we cannot eliminate the AMR. What we can do is by making action now, we could in the long term suppress the burden of AMR in the long term, like as we show in the graph in the right bottom. One of the priority actions we are taking at the regional office is to estimate the AMR disease burden in our region for the next 10 years. This is a preliminary result and unpublished yet, but according to our estimate, in our Western Pacific region, in over the next 10 years, there may be 5.2 million excess deaths and 148 billion USD excess cost if there is going to be a worst case scenario in over the next 10 years. This is a little bit difficult to understand what is the impact of these figures, so we try to compare with other disease categories or other diseases. So this is a comparison between AMR and the other diseases, including infectious diseases and the non-communicable diseases, with a crude death rate per 100,000 population. So this is an estimate how many people might die because of this disease per 100,000 population. So our estimate shows maybe 23.5 per 100,000 population for AMR. This is far larger than the estimated deaths from HIV/AIDS, for example, and then also with the tuberculosis. And then it's also a little bit larger than the excess deaths estimated from the diabetes mellitus. Again, this is unpublished data, but we are hoping to publish this anytime soon. Let's move on to talk a little bit about the surveillance. What is a surveillance? Surveillance is the information for action or action-oriented information. So surveillance data should contribute to the public health action, including informing the clinical practice to save life of the patient. Main surveillance component for the AMR surveillance is a passive surveillance using data from routine clinical practice from sentinel hospitals, but often this is not enough and it should be supplemented by active surveillance, including a previous survey for the particular pathogen or infectious diseases, or the sentinel site surveillance for a particular pathogen, like Neisseria gonorrhea, and then research, and then also event-based surveillance. I would like to stress here again the importance of a hospital-level surveillance because drug resistance pattern can be different in each hospital, and then to improve the clinical practice, ideally each hospital need to develop and then regularly update their antibiogram, which shows what is the rate of susceptibility or how effective antibiotics is for this particular bacteria using their own data so that they could inform clinical practice. Here, AMR surveillance should not be just for the lab, but such information derived from the AMR surveillance should be closely shared with other counterpart or the related parties, including physicians, pharmacists, nurses, epidemiologists, so that actually this information from the surveillance becomes the information for action to improve clinical practice. WHO have a global AMR surveillance system called GLASS, and then there are more than 100 countries which have enrolled in the AMR surveillance component of the GLASS. However, we have to admit that one of the significant limitations for GLASS is there's still limited feedback to the country, or especially to the hospital levels, using this data collected through the GLASS platform. So this is the reason our regional office is very much focusing on the support of AMR surveillance at the hospital level. Let me just ask a question here. Do you think where more antibiotics are prescribed or used? Number one is for inpatient at hospitals, or number two, outpatient or out of hospital settings? The answer is very clear. This is the antimicrobial consumption data collected from 7 countries and areas from our region. And then here, blue shows the proportion of oral antibiotics. And then in most countries and areas, oral antibiotics are prescribed or occupy more than 90% of total consumption. And then the parenteral or injectable antibiotics are just less than 10%. At our region, WIPRO have established the regional platform and the methodology, which is called WIPRAX, Western Pacific Regional Antimicrobial Consumption Surveillance System, to support building a system or further strengthen a system for antimicrobial consumption monitoring across our region. to increase multi-stakeholder accountability and then strengthening stewardship of antimicrobials, and then clinical practice to improve health outcomes. This photo on the right-hand side is a photo of the first regional report, which was published in the January this year, which summarized antimicrobial consumption data from 7 countries and areas. WHO have AWARE classification, meaning that we have categorized commonly used antibiotics into 3. Number 1 is access, number 2 is watch in yellow, number 3 is reserve in red. And then we are encouraging the country to use access category antibiotics for more than 60% of the total consumption. From the WIPLAX data, as we can see, 4 countries here have access antibiotics in access categories for over 60% of entire consumption. And some countries have a lower percentage. Have access antibiotics with a lower than 60% percentage. Lastly, I would like to introduce a new publication from WHO. Number 1, our regional office have recently published the guidance to respond to outbreak of AMR pathogen in healthcare facilities, with the purpose of providing a step-by-step guidance for the healthcare facilities to respond to outbreak of AMR pathogens, basically bacteria. This is a practical resource for healthcare workers or public health officials to utilize to support AMR outbreak response in low and middle-income countries. This guidance includes, for example, practical 10 steps which should be taken to respond to the AMR outbreak at a healthcare facility, and also the risk assessment chart to make a judgment how serious this AMR outbreak should be or can be, and then whether you should report this outbreak to the public health authority, either local or central or national. Our regional office is planning to host a webinar to introduce this outbreak guidance, and then also to inform how we are planning to support capacity building for the AMR outbreak response for the member states. This is scheduled in the 6th of December this year. Next new publication is the WHO First Fungal Priority Pathogen List, or what we call FPPL. So this is the first WHO report which categorized fungal pathogens, and then notably in the critical group of the utmost importance, we have categorized cryptococcal neoformans, which causes cryptococcal meningitis, and then Candida auris, which has a high mortality rate with its infection, and then 2 very common fungal pathogens. Number 1 is Aspergillus fumigatus, and number 2 is Candida albicans. With this categorization and official publication, now we could focus our investment to tackle with the pathogen or fungal pathogen with high priority. So it can be useful for the public health interventions, and then also the surveillance to prioritize which fungal pathogen, and then also focus on the funding for the research and the development. For example, to develop a new therapeutics for such fungal pathogen with a high importance. So we are going to go to the concluding slides. What are our next steps and priorities? Number 1, advocacy strategic communication for policymakers and the general public to further increase awareness among them, to advocate and move towards the AMR movement, where everybody makes some action to fight AMR in their professional life or in their daily life. Number 2 is to strengthen AMR surveillance, especially at the hospital level, to inform clinical practice. Number 3, enhance appropriate use of antibiotics with prescription using antimicrobial consumption data. Number 4 is monitoring the AMR burden to inform policy and especially for the advocacy. I am showing the same slide for the take-home messages here. I will not repeat, but these are the points I would like you to take home today. So this is acknowledgement, and then thank you very much for your kind attention and then this opportunity to present. Thank you very much.
Okay, does that will look good from your end?
Looks good.
Great. So Bula, good morning everyone, and thank you very much for the opportunity to present today as a part of your World Antimicrobial Awareness Week webinar. So my presentation is on the One Health approach to addressing AMR. So I think many of you have probably seen this diagram before. It's a nice picture. It shows the complexity of AMR. AMR that's impacting the health of people, livestock, pets, wildlife, aquatic species, crops, and essentially AMR occurs in all species in which antibiotics are used, and even some in which it isn't used, such as wildlife and some wild fish species. And there are also many mechanisms for transmission of resistant bacteria and resistance genes through contact between people and animals, contaminated food, contaminated drinking water, sewage, wastewater, soil runoff in rivers, and even things like flies. So AMR is what is referred to as a wicked problem, like climate change. And this can really only effectively be addressed through a One Health approach involving multiple sectors, disciplines, a multi-site society approach. I just thought I'd go back and start with the One Health high-level expert panel, which was set up last year with 10 experts from different countries and sectors to advise the quadripartite, the World Health Organization, FAO, WAAW and UNEP about a One Health approach. So one of the first things that this panel did was agree on a definition of One Health, which is shown in the slide. And it's really been very helpful to get a globally accepted definition of One Health. So you can see from the slide, One Health is an integrated unifying approach that aims to sustainably balance and optimize the health of people, animals, and ecosystems. It recognizes the health of humans, animals, domestic and wild animals, plants, and the wider environment, including ecosystems that are closely interlinked and interdependent. So this is what we aim for. They've also produced a nice graphic to support this, which just shows sort of a comprehensive approach to One Health. On the left, it refers to the collaboration between the multiple sectors and the multiple disciplines to address issues that affect humans, animals, and the environment. And on the right, it shows the multiple scales of society from global to local, at which One Health can be applied. In the middle, we have what's been referred to as the 4 Cs, which achieve a One Health approach. So we've got communication, collaboration, coordination, and capacity building. And at the bottom, the expected outcome of a One Health approach, which is healthy humans, animals, and environments. So just to show that these resources have been prepared by the expert panel, not going to go into any detail, but just really letting you know that these are available. There's the quadripartite has produced a joint plan for action that is supporting a One Health approach in the 6 areas shown here, which includes antimicrobial resistance. And then they've also produced a One Health theory of change, which shows the inputs and the pathways to achieve a One Health, or to achieve the outputs expected through a One Health approach. Ultimately, better health for all. So moving now to AMR specifically, and the One Health approach with AMR. As indicated in the high-level definition, One Health is implemented at multiple levels in society. So I'm just showing here some levels, some examples of One Health at the different levels. So we've got the global level, where there's global leadership and collaboration for AMR is provided by the quadripartite, which includes WHO, FAO, WAAW, and UNEP. At the regional level, the Pacific community is working towards providing leadership in One Health in the Pacific region. And there may also be collaborative programs involving WHO, FAO, WAAW, and UNEP. At the national level, NARC is providing governance and leadership in facilitating a One Health approach to address AMR, and providing a really nice model of a One Health approach to address health issues in general. And then also there's the multi-sectoral technical working groups, which provide national leadership for collaboration in One Health. And then at the local level, there's a lot of collaborations for different programs. And I've just put a couple of examples here. For example, say antimicrobial stewardship programs in the community involving pharmacies, clinicians, communities, farmers, veterinarians, paraveterinarians, social scientists, community communication experts, and others. And likewise, implementing infection prevention and control programs. So looking at each of the, let's look at some examples at the governance level, at the national level. So Shona in our next presentation is going to address more detail governance for AMR in more detail. Here I just reiterating, I guess, that the National AMR Committee is essentially responsible for producing the National Action Plan for AMR that addresses activities across, oh, sorry about the lighting here, across the human, animal, environment and agriculture sectors. It's responsible for prioritising activities in the National Action Plan and ensuring that there's resources for these. I mean, there's so much to do. It's working out, what are the priorities that can be done with the resources that are available and seeking funding and allocating these. Putting in place the necessary legislation and administration support for implementation of the NAP, monitoring implementation of the National Action Plan, and then addressing issues that are associated with the implementation. And facilitating a One Health approach within NARC itself. So providing opportunities for all sectors to present updates on their programs, to present on progress and outcomes and challenges, and useful and interesting findings. Moving to the technical working groups. So One Health collaboration in the technical working groups. In Fiji, you have, I think, 4 major technical working groups that I've shown here, and I think also a few others. But major ones are relating to AMR surveillance, antimicrobial stewardship, antimicrobial use surveillance, which this may be a part of antimicrobial stewardship technical working group. It might be a part of the AMR surveillance technical working group. So you have a surveillance technical working group covering AMR and AMU, or it might be a technical working group on its own. And then infection prevention and control, and as I say, some other areas. So I'll just go into a bit more detail on how the One Health approach can work in some of these areas. So looking first at surveillance, AMR surveillance. So AMR surveillance, it's not one thing. It's really very broad if you think about the complexity of AMR. And to apply a One Health approach, it needs to be to include a number of different streams or sources of AMR surveillance information. So it'll include data from different sources and probably with different objectives. Essentially, there's two aspects to AMR surveillance. So there's sector-based surveillance, which is producing data on AMR in each sector and understanding AMR that impacts the treatment of pathogens in humans and animals, in plants and fish. And then there's integrated surveillance, which produces produces data that understands movement of antimicrobial resistant bacteria and genes between humans, animals, plants, and the environment, and is useful for identifying interventions that might reduce the risk of transmission. So One Health Surveillance Technical Working Group provides the technical leadership for the One Health AMR surveillance, identifying priorities for surveillance, helping to design the surveillance to get the samples and the data that's needed, monitoring the lab results and checking the quality of the data's coming through, and providing technical support to improve data, and then understanding the antibiograms and interpreting cross-sectoral results, interpreting AMR results in the context of AMU surveillance, and communicating the results to the National AMR Committee and then also to other stakeholders. So with AMR surveillance, we're really, in One Health AMR, many countries are still in the AMR discovery phase. There's really little data on AMR in all sectors. Insufficient data to understand what are the major resistance problems in each sector. How big are they? What's driving them? And then what resistance is being transmitted between populations and how. So at this stage, we're learning and building a One Health approach by doing the surveillance, by gathering data, by sharing and interpreting data together. So discovery together. So as I was saying, AMR surveillance, One Health AMR surveillance covers multiple sources of AMR surveillance data, as we can see in this slide. So you've got hospitals, communities where data can be generated through or gathered from the primary healthcare system, from GPs, or perhaps directly sampling people in the community to understand community levels of carriage. Then animals, you've got all different species of livestock, and then aquatic species, and there's also pet animals, and then you have food and different types of food, meat and vegetables, and then the environment. There's quite a lot of interest now in sampling sewage and testing sewage for AMR, for resistant bacteria and resistant genes. And for example, using sewage and outflow from hospitals as a way of understanding a wider or more complete range of resistance that's present in the hospital, more complete than can be obtained through sampling and testing samples from individuals, say sepsis or urine samples. Then also testing sewage as a reflection of resistance that's within communities, and then in surface waters or rivers, understanding, by sampling at different locations and sort of pristine areas where the rivers are moving through farmland, and then communities to understand the introduction of different resistant bacteria genes into the flow. also sampling wildlife to understand they might be sentinels and indicators of resistance that's to the environment. So there's collecting samples from all these different species and sources and systems in place for those. And then these samples need to be cultured and identified, antimicrobial susceptibility testing conducted, and to get phenotypic patterns and analysing the data for the anti-biograms or AMR patterns. And then there's whole genome sequencing and identifying isolates that are priorities for conducting whole genome sequencing and understanding the genotypic patterns, which are essential for understanding priority resistances, understanding the epidemiology, and identifying appropriate interventions to control these. There's also the area of metagenomics, where you skip the sort of phase of culture and AST and profile and understand the presence and abundance and heterogeneity of different resistance genes in samples, which is a growing area at the moment. So there's multiple streams. Funding is needed for all these, and the technical working group is really the key to implementing and integrating these different surveillance sources. So this diagram is really showing sort of a way, I guess, of pulling the different surveillance sources of data together. I think it's important that each sector has its own surveillance system for collecting and testing resistance and analysing and understanding their results. And then bringing these to the One Health Surveillance Technical Working Group to understand what's happening in each sector and the links across sectors. So showing here in the different colours, that starting at the bottom, you've got the sources of samples and the laboratories for testing. Then there's reference laboratories, and there's also potential for reference laboratories to be to support the different sectors. So you might have a reference laboratory specifically for human health, but that reference laboratory may also be able to provide a reference lab service to the animal health and the environmental health. You know, in a smaller country such as Fiji, you know, it makes more efficient use of resources. And then you may or may not have a technical working group that is managing the surveillance in that sector, analysing the data out of that sector, or that that sort of sector-based technical working group function is actually provided within the One Health AMR technical working group, you know, which is the case in some of the smaller countries where there's not a separate technical working group for each sector, but the One Health group manages across each sector as well as in pooling sector. So in the animals in the middle here, we've got data and samples from animals, from fish, from food, and these might all be managed through the same laboratory, the same technical working group, depending on the administrative structure of a country. And then environment, and if there's an existing laboratory that's under the management of the environment sector, maybe for testing water quality, you know, the capacity might be built in this lab to do the AMR surveillance, or there's potential for environmental samples, say, to be tested by the animal health lab, which again can improve the efficiency with which resources are used in a country. So rather than, say, setting up a new lab for environment, having environment samples tested within the animal health lab, which improves the utility and efficiency of this this particular laboratory. Then the One Health group pulling all the results together, looking at the major resistances in each of the sectors, understanding where there's transmission across sectors, and then making recommendations on improving surveillance or adding different objectives to the surveillance to gather new data, and where there is enough data, recommending some priorities and interventions, and presenting this to the National AMR Committee, presenting on monitoring and where things are at, the results, and then also recommendations for policies and interventions. So moving now to AMU surveillance, again, it's the same as AMR surveillance. You've got multiple sources of data across the multiple sectors. So we might be looking at what antimicrobials are used in the different sectors. This can be within the community, say collecting and understanding data through the community pharmacies, through the primary sector, or within hospitals. In farming, understanding what antimicrobials are used in the different farming, the different livestock species, what is used, how are they being used, and how appropriately are they being used. And producing this data, and then it can be useful for linking with AMR patterns. So understanding if there's drivers for antimicrobial use drivers for the AMR patterns, understanding use of critically important antibiotics, and whether there's a need to be managing this so that they are reserved. And that's critical antibiotics that are needed for treatment of humans and animals and plants. So what's critical for each sector, and what interventions are necessary to retain those critical antibiotics so that they are available for treating the important bacterial diseases in the different sectors. And then formulating stewardship programs for each of those sectors, address the particular use issues that have been identified. Looking at food and the environment, there's the systems need to be put in place over time to understand antimicrobial residues. So what's present in meat that might be a risk, and other food products that might be risk to humans. What antimicrobials are present in the environment, and these might be driving resistance for bacteria in the environment. What are the different sources of antimicrobials in the environment, people, animals, pharmaceutical industry. And then again, putting in place, understanding the risks and putting in place programs such as ensuring withholding periods that appropriate antimicrobials are used, are being applied. Looking at antimicrobial stewardship, again, the One Health Antimicrobial Steward Technical Working Group brings together the different sectors to address stewardship in the different target populations. So looking at clinicians in hospitals, probably looking at particular wards in ICU or surgery or pediatrics, where are the issues around antimicrobial use that need to be, and working out programs to improve the responsible use of antimicrobials and preserve antimicrobials for future use. Working with GPs, is there an opportunity to reduce use of antibiotics in GPs? And just the previous speaker was just showing the number of the ratio of oral use of oral antibiotics compared to parenteral. Community pharmacies, how might community pharmacies contribute to reducing AMU in the community? For example, say providing antibiotics on prescription only. The photo that's shown in this slide isn't actually Fiji, but it is just it is an indication of the challenge that we have in people having sort of limited access to antimicrobials in the community. Working with veterinarians or paraveterinarians, so is there a need to reduce or to change antimicrobial use? And working with farmers. Are farmers accessing antibiotics from without veterinary or paraveterinary advice? And what antibiotics are they accessing, and from where are they getting these antibiotics? And what's the potential impact of these antibiotics? And so designing programs to try and address and manage that. Infection prevention and control, again, targeting programs for different groups. So the membership of the technical working group has representatives from the different groups so that can work together to design programs. So infection prevention and control in hospitals, say to reduce the transmission of hospital-acquired infections, addressing hygiene in the community through WASH programs to reduce transmission between people, within households, within the community, ensuring clean drinking water, addressing biosecurity on farms to reduce the level of introduction of resistant bacteria and bacteria in general, or actually any disease, because the more introduction of disease and viral diseases, the more antimicrobials are used. Creating a more hygienic environment, managing things like mastitis or pig and poultry environments, and then vaccination programs to prevent infection. You don't have Newcastle disease or foot and mouth disease in Fiji, but in a number of countries, these are prevalent, and they're actually a major driver of antimicrobial use, which isn't going to treat the disease. It's an inappropriate use, and it's an area for potential reduction of antimicrobial use in animals. So in summary, AMR impacts all species in which antibiotics are used, and it's the responsibility of all sectors to address AMR. And to do this, it's important that all sectors are resourced to address AMR within their sector, so that they have the skills, the tools, and the resources to actually implement programs within their sector. And finally, the One Health approach is important to, as a framework for all sectors to work together, to share data, to share approaches through the technical working groups, and to provide data to inform interventions that are going to control antimicrobial resistance within the sectors. And it's important that, that there's strong leadership to support a One Health approach. And I'd just like to finish by commending NARC, I think, on being on your strong support for the One Health approach, and facilitating this within the National Action Plan. And I guess finally, the really important thing is to bring all the sectors together and address AMR across all the sectors. Is to ensure that the National Action Plan has objectives that address issues in the sectors, and there are resources for each sector to implement their programs. So with that, thank you all for your attention.
Thank you so much, Dr. Joanna. I'd like to thank Dr. Joanna for her continued support of NARC and her expertise in One Health. So thank you so much. Lovely presentation. Thank you for your insights. Do we have any questions for Dr. Jo at this stage? I believe you have to leave after this, you mentioned.
Yes, I'll stay for a little while, but I do have to drop out for about half an hour, but I'll come back for the panel discussion.
Okay, thank you so much. There are no questions in chat or anybody? All right, so I guess we'll move on to Dr. Shona.
Hi, Renal, thank you.
Hello.
Shall I share my presentation?
Yes, please.
Can you see my screen?
Yes, we can. Thank you.
Thank you, Renal. Thank you for the invitation to talk with you today. I'll keep my presentation element short in case anyone has any questions, because unfortunately I have a meeting with the Australian Department of Health following on from this, so I will not be able to make the panel discussion. So upfront, I wanted to say that this is a project component, part of a bigger body of work enhancing the management of antimicrobial resistance in Fiji, or the AMR project led by Walter Okello. This work was undertaken by my colleague Rachel Williams and I, with many of you who are on the call today. So I'm going to just share some of our collective insights. So I've heard, well, we've all heard a lot from Joe this morning, so this presentation actually builds very beautifully on from what Joe was talking about. We know that effective One Health decision-making is key to manage AMR. Joe's presentation gave a good example of how AMR transfers between human, livestock, and the environment, and that human health, livestock health, and environmental health are currently governed separately, but actually need to have connections to ensure we're able to address antimicrobial resistance effectively. So these domains are affected by each other, and that means we need to get better at understanding the context of the decisions that we're making in. So the picture here is a heuristic that some of my colleagues created, and we use it in these wicked complex decision contexts, whether it's about antimicrobial resistance or to do with climate adaptation. So to make a decision, that's the central circle in the middle, you need to have the knowledge, and a lot of us in the science domain really focus on the knowledge. But critically, in order to make that decision, you also need to have the rules to enable you to make that choice, and you need to be able to value or want to make that decision or address an outcome. And this can be a challenge when different domains or groups of people have different values and abide by different rules, so that you actually will struggle to find that decision context. So what do we mean by governance? And it's used very differently in different sectors. So here, what we mean is the process of decision making. It includes actors, which are people and organizations, formal rules such as laws and regulations, but also, and critically important, informal rules. So these are the social norms, cultural conventions, traditional laws about why people do things that they do. And so I won't go into it now, but we've created a little video, which you're welcome to go and have a look, that actually explores the nuances of what governance is and how it impacts decision processes. So there are some One Health definitions of governance. And again, critically, there's differences in how people define this. So governance can be around how decisions are made and implemented, and has two uses, according to Greer: the description and analysis of what is, and a picture of how it could be or ought to be. And it's also the combination of the formal and informal institutions, rules, and processes that influence global decisions in health policy. But those global decisions, as Joe outlined, cascade down as well into other sectors. This is slightly different from stewardship, which is the careful and responsible management of something entrusted to one's care. So if you think about governance as the structure and the pattern, where stewardship can be the activity. Sorry. So who's involved? We've mentioned before that it's people, individuals, social groups, communities. It can be organizations such as businesses, NGOs, and government. And that these groups operate at these different levels, whether it's at the local level, a regional level, a national level, or international. And it's how we connect those decision types together. So there are many attributes for good governance. These are some of them. I'm sure you can come up with many more, but critically, it's about participation across all the different sectors and levels. It's around having the capacity to implement and design policies that help inform these decisions. It's about holding people accountable. In a lot of countries, we have really good policies, but less accountability to actually make sure that people follow through. Then there's transparency, which is important for fairness as well as for people understanding what's happening. And then there's integrity. People are this is closely linked to the accountability. People doing what they say they're going to do and being held to account. So building One Health governance capacity is actually important in all countries. In Fiji, through the AMR project, we wanted to gain a better understanding of where Fiji was at in terms of the current rules and processes designed to contain AMR in Fiji, what the roles and responsibilities were, who's responsible for doing what, and how do they connect. The processes for containing AMR and how they're meant to work and how they actually work in practice. I've worked in climate change for about 15 years in the Pacific, and there's a lot of really good rules which are not actually implemented. So we wanted to check how things work in Fiji. And we wanted to identify the gaps and areas for improvement. So these are the intervention points that Joe was mentioning, these opportunities for enhancing cross-sectoral decision-making. If you look at the little cartoon of the elephant on the bottom right, you'll notice that each of the scientists is looking at a little part of the system. And until they actually get together, you might have the person at the head of the elephant thinking he had a spear. You've got the lady underneath the elephant thinking she's got a tree. But unless they actually start talking together, they don't know what they're dealing with. And this is the same for AMR. So some of the activities that we did, we mapped out the interconnected rules and actors, showing points of intersection between different areas of jurisdiction in Fiji. And then we created a series of example narratives about how some aspects of One Health decision-making are working for AMR in Fiji. And we use these stories because people can engage more effectively with stories and than frameworks. And it helps people describe what's happening and how people feel it should happen. And I'll show you a few examples of these. We then hosted 3 online workshops in May with our Fijian colleagues. Unfortunately, we would have loved to have done these face-to-face, but travel is still somewhat restricted for us in our organization. So we wanted to use these workshops to review how the system is supposed to work, share insights about what is actually happening and why, and then identify options for improvement. We had workshop participants from Ministry of Agriculture, Ministry of Health, BATH, FNU, CSIRO, and University of South Australia. And we explored 3 example stories. The first one was about antibiotic imports for both animals and humans. We looked at antibiotics in meat, particularly beef, and wastewater from slaughterhouses and the impact on the environment. So we wanted to take slices that crossed sectors, but made sure that we could tell a story that would resonate with at least some people in our workshops. So this is the mapping of the actors and rules. So you can see that we started with the Fijian Constitution. We looked at the various ministries involved. So in addition to the Ministry of Agriculture and Fisheries and Health, there's also the Ministry of Education, the Ministry of Finance. So there are these other players that are involved in this decision context that need to be considered. There's also the international community, research organizations like FNU and USP. Underneath this, there's a collection of legislation or acts that actually help govern what the formal rules are for how AMR is governed. Each of these stars represent who's on the NARC. So as Jo mentioned in her presentation, the NARC actually has a really good representative across the Fiji decision context, although, and we'll get to this a little later, we do know the actual actioning of that cross-sectoral coordination has a few little gaps. We then created a set of decision narratives, and my colleague Rachel Williams has hand-drawn these to show This section is around the importation of drugs and the different groups that are involved, like BAF, Ministry of Agriculture, Customs, the pharmacies, and the Ministry of Agriculture clinic. Then the clinic works with groups like the beef farmer, dairy farmers. With the beef farmers, once their cows are ready, there are animal transporters involved. There are elements of Ministry of Agriculture through meat inspectors. We've got vets, we've got slaughterhouse managers, we've got administrators, we've got other inspectors. So you can actually see the story flow through the system. Critically, at this point, meat turns into food, and so the rules start to shift about who should be involved. So in this case, it's a food inspector instead of a meat inspector and the butcher. So some of the stories and insights we've come across is the different rules governing the different types of inspectors, and maybe sometimes there's a lot of overlap and sometimes there's a gap. Another theme we had was about medical waste and the impact on the environment, with the challenges of having a broken incinerator, meaning that out-of-date antibiotics and other medical waste goes to landfill, which actually starts interacting with the Department of the Environment and the landfill operator. Now, runoff from the landfill goes into the environment, which becomes a public health hazard. So you can actually see how the different stories all start to flow together. And we have a report imminent on this that actually tells some of these stories. So the insights from these workshops was a list of some of the gaps that came up while telling these narratives. There was a challenge around the importation of drugs, with BAF dealing with Ministry of Agriculture and Customs dealing with Ministry of Health, but we do understand that these gaps have been addressed currently. There was challenges around GP and pharmacy prescriptions, with the lack of private sector oversight and a culture of doctor shopping. I think Joe's picture was a good example. I note it wasn't Fiji, but the fact that a good doctor provides or a good chemist provides, and you don't need a script, but this leads to challenges of poor antibiotic stewardship. There's a challenge with the awareness of AMR in livelihood sectors. We learned that within Fiji, there's an emphasis on protecting farming livelihoods. It's a similar issue in Australia, but combined with the low government awareness of AMR has meant that in the past, sometimes ministers will override restrictions on the way that farmers access antibiotics. So we knew through the COVID restrictions and everything had to change, that sometimes farmers could actually go to pharmacies to get their antibiotics, which produced some gaps in the stewardship process. I mentioned the disposal of antibiotics and biomedical waste, the challenges of the working biomedical waste incinerator, and the lack of clarity of the role that this plays between Ministry of Health and the Department of the Environment. And mentioning before that the challenge of getting the environment engaged through the NARC has been an ongoing issue. This is potentially because of the lack of awareness of AMR in the environment, and DOE's relative inactivity with the NARC and the disconnection between the different ministries, but there are opportunities here as well. There was also a challenge around the awareness and roles in the meat industry. Abattoir waste is a significant risk for human AMR transfer via environmental factors such as rodents, birds, and wastewater. And the fact that as the population has grown in Fiji, that the urban area has got closer to where the abattoir is. And then I mentioned before the role of inspectors, whether they be food or meat inspectors, isn't 100% clear. And across the board, people mentioned the need to raise capacity in all sectors. But as I said, there were potential areas identified for action about how to deal with expired antibiotics, increasing regulation of the private sector, restricting access to giving antibiotics to animals through vets rather than through pharmacies, making a connection between AMR and the economic impact with government, such as via the Consumer Council, working out how to engage and make the case for Department of Environment to be more engaged. As always, updating old legislation if it's relevant to update. Sometimes old legislation is still very good, is checking to see whether it still does the job of work that you need it to do. We've heard that there are already increasing links between BAF and customs, so this is wonderful. Challenges with increasing inspections at the abattoir, and the fact that this particular abattoir supplies the tourism industry, which may produce challenges of the future. Clarifying roles, whether it's about the meat and food inspectors or in the abattoirs, and again, building capacity across all the sectors, as well as raising awareness in the community. So I just wanted to say thank you very much for listening to me. What I've presented is an example of a tool that we hope that you can use in Fiji to actually start exploring some of these One Health interactions and developing these stories and narratives with each other to actually try and identify both the gaps and the opportunities for how to address these gaps. Thank you very much.
Thank you so much, Shauna. It was a fun workshop to be part of, and just wondering, is there plans to do a follow-up for this one? Maybe after 1 year gap or something?
I think that would be a wonderful idea, and it's something that I think I think I saw Walter on the line a little earlier. I think if we could gain further funding from funder ACR and DFAT and explore the work forward in this space. I mean, clearly that scope of work would have to be negotiated with partners in Fiji as well as the funders, but I would like to think that this area of governance and decision making had a role to play in the future.
Yeah, I think it was a insightful workshop, especially in identifying what the problem is and where the gaps are. And I think there's like some work being done to move things along, and it'll be good to see if there's some progress in these areas. So very good.
That's great. I'm very pleased to hear that it's had ongoing use, which is what we hope to achieve through this process.
Yes, thank you. If there are any questions for Dr. Shauna, I think she's going off after this.
I can stay another half an hour, but then I'll have to leave.
Okay. So I don't see any questions in chat, but I guess we will move on to our, the last presentation is actually a recorded presentation from Dr. Nahako from the World Organization for Animal Health. I'll try to bring it up now. Hold on. Let's hope this works. Share screen. Share sound. Share.
Good morning to you all. My name is Nahoko Ieda, and I'm AMR Regional Project Officer at Regional Representation for Asia and the Pacific of the World Organization for Animal Health located in Tokyo. First of all, I would like to thank the organizers of this event, National AMR Committee members, and Biosecurity Authority of Fiji, who gave me this wonderful opportunity to talk about our organization's activities in the area of AMR and MU in this occasion of the World Antimicrobial Awareness Week of 2022. Today, I'm going to briefly introduce the WAAW strategy on our action against AMR, and then our recent activities along with our 4 action pillars. Many of these have been, of course, participated by Fiji, mainly through Biosecurity Authority. But if you find any other activities that are interesting to you or relevant to your stakeholders, please do feel free to approach us by sending me an email directly or to my colleague Dr. Elva, who is with you today on the site. Just a very brief background. The current situation regarding the AMR in Asia-Pacific region is that there are weak legislations to regulate import, production, sales, and monitoring of antimicrobials. Inadequate supervision on usage of antimicrobials in animals, use as antimicrobial growth promoters without risk analysis, and weak AMR surveillance system. The critical outcome of these situations is, out of many others, the inappropriate use, which leads to development of AMR. Our general session is the time when all the delegates and representatives of WAAW members gather in Paris once a year and discuss the most critical issues in the animal health sector. In the general sessions in 2015 and 2016, they adopted resolutions that defined WAAW's role in promoting the prudent use of antimicrobial agents in animals through One Health approach. And to do that, it was decided that WAAW would develop an annual data collection system, establish a global database, and manage the data on the use of antimicrobial agents in animals in the world. Following these resolutions, WAAW launched its own strategy on AMR and the prudent use of antimicrobials. It has 4 pillars of objectives: improve awareness and understanding, strengthen knowledge through surveillance and research, support good governance and capacity building, and encourage implementation of international standards. In the following section, I will introduce some of WAAW's actual activities that we are carrying out in alignment with these WAAW's strategic objectives. So to achieve our first goal, improve awareness and understanding, this set of infographics were developed to show good practices for antimicrobial use in simple 5 rules targeting general audience. The 5 rules go: only use antimicrobials when associated with good animal health care. Only use when needed. Antimicrobials do not cure every infection. Only use antimicrobials when prescribed by a veterinarian. Only obtain antimicrobials from authorized sources and retailers. Only use the dosage and follow length of treatment and withdrawal period as described. We also develop technical materials targeting professionals like veterinarians. This is our recently published guide for veterinary authorities, how they can play their unique role in fighting AMR. There are also guides for feed manufacturers and pharmaceutical industries, and farmers and retailers. More are coming very soon. These are different sets of information depending on who the audience is, because we think it is very important to deliver the concise but specifically relevant information to each actor of the antimicrobial use in animals. We previously translated such AMR awareness materials and posters and leaflets into various local languages that are used in Asia and the Pacific region, such as for Bhutan, Cambodia, Indonesia, Malaysia, and so on. It is very important that, particularly for our region, to have a wide range of language covered, because our region is so diverse in cultures and languages, as you know very well, and it is very likely that our audience and stakeholders don't use English daily. So far, we don't have Fijian translations by now, but if you find this initiative important for your stakeholders, please contact us and let's find opportunity to add Fiji in this list. The next pillar I'm going to talk about is strengthen knowledge through surveillance and research. This objective has been tackled through our flagship program of the data collection for global database on antimicrobial agents intended for use in animals. In the past 6 years, we have been annually publishing a so-called AMR report, and the data are collected from our members and reported globally, aggregated globally and also by regions. We can see a gradual but clear increase in participating members since 6 years ago. Fiji is of course one of them, and I'm expecting your contribution for the 7th cycle data collection that is going on just right now. According to the latest report, it seems that our action against the AMR is working well at some extent. The use of antimicrobials that is critical to human health is declining in animals by 62% for the class of polypeptides and by 43% in macrolides. And as you can see in your right side, the use of antimicrobials for growth promotion is no longer a practice in 69% of our participating members. Because the AMU data collection is a highly technical and complicated process, we offer in-country workshops on monitoring AMU data and invite government technical officers to improve their capacities. During 2018 to 2020, we provided the training for the members in the region in turn. Physical meetings have been unfortunately suspended during the pandemic. So March 2020 for Pakistan was the last time we had a physical workshop. We did organize a virtual one for India last year, but such a training in-person meeting is much more effective, especially in a low to middle income countries contexts where technical support is needed. So we are hoping that we can get back to the original track very soon. And again, if you find this in-country workshop is useful for your country, please let me know. We need a bit of time to prepare and find fundings on this, but I'm definitely up for discussing with you further. Our third objective is to support good governance and capacity building. So I'm showing a couple of examples. In WAAW, we have a national focal point system in each member country who are appointed by WAAW delegates as a counterpart ministry. Often it's Ministry of Agriculture or Ministry of Livestock, sometimes Rural Development. In Fiji's case, the delegate and many of your focal points are appointed from Biosecurity Authority. And in the area of AMR issues in AMU, our focal point for veterinary products are the contact point. In order to facilitate WAAW's programs, we provide opportunities for in-depth technical discussion among the members. So we have been offering biannual training seminars to the focal points for veterinary products since 2011. The last one was in this April, and it was a virtual meeting due to the pandemic, similarly to the other workshops. But we are hoping to resume the physical training from the next cycle. And this picture was taken in Bangkok in 2018, and I think our focal point for veterinary products, Dr. Chaminda, is in the photo. It must be a small picture, but you can ask him to confirm later. Our regional office has its own laboratory capacity building program as well, which had been on-site practical training before the pandemic at WAAW Collaborating Center in Japan. National Veterinary Assay Laboratory of Japan is our collaborating center for AMR, and there AMR laboratory technicians from different member states came over to Japan and went through short-term or mid-term practical trainings. Again, it has been suspended for the reason of pandemic, but we are now thinking of resuming it gradually. Firstly, through webinars and virtual follow-ups, and then hopefully resume on-site trainings in the near future. This virtual mentorship is under discussion with NVAL, the collaborating center. But as soon as the details are fixed, I will share it with you, the information through our focal point of veterinary products in Fiji. The last pillar I'm going to talk about is to encourage implementation of international standards. When we talk about international standards, the overarching umbrella is the sanitary and phytosanitary agreement that are agreed by the member states of World Trade Organization. Under this, amongst the different sectors in food production systems, animal health is primarily adhered to as WAAW through our codes and manuals. On the other hand, crop health, as well as food products, are under WAAW's standard. As you can see here, for all of us, it is inevitable to collaborate with other international organizations such as FAO when we support our members to implement the international standards. Needless to say here, in the occasion of One Health seminar, but One Health is, of course, the essential approach when we try to tackle cross-sectoral issues such as AMR and food safety. And I would like to highlight that UNEP, the UN Environment Program, has recently joined the global team that has been with FAO, WHO, and as WAAW before. As a part of the WAAW activity last year, the regional quadripartite developed awareness-raising videos to combat AMR with animations. Now it's available on WAAW's website. In collaboration with some of our member countries, we also translated it into different languages. This could be also done for Fijians if you find it good collaboration opportunity with us. So you are most welcome to contact us for this. The last project I introduced from our quadripartite is this country self-assessment survey. This survey is sent out to the member countries through WHO office on behalf of the quadripartite organizations, but all the others, FAO, WAAW, and UNEP from this year, we are involved in the development of the questionnaires. The results are accumulated at this global database website every year, and you can do your own search. I'm going to share with you only 2 of the results today out of many, but this first one shows the development of implementation status of national action plans for AMR. The left map indicates the situation in 2016-2017 when this annual survey was started, and right is more recent situation in 2020 to 2021. The red shows the countries without any action plans at national level. Orange shows it's under process, yellow shows the action plans are developed, green shows it's started being implemented, and dark green means they are now monitoring and evaluating the implementation of the national action plans. As you can see, when this survey was started, only a few had prepared and implemented the national action plans to act against the AMR. But in the latest result shows that the most of our members in the region have at least developed the action plans, and some of them are already monitoring and evaluation, so it's a good progress. Fiji was actually in green status from the beginning of this survey, so you have been really one of the champions in our region. The next set of the maps show another progress, particularly in animal health sector. This question was regarding the training on AMR for veterinary professionals. Compared to the overall national action plans, this particular area seems to be a bit behind. Like in the past, only a few countries were implementing a fully integrated training or curriculum for veterinary professionals regarding the knowledge on AMR. But by last year, we can see certain progress have been made as many countries shifted from red to orange or yellow to green. Fiji's response in 2021 was that AMR and prudent use of antimicrobial agents are covered in core curricula for veterinarians in some educational institutions, which is great. And if you're interested in any technical support from WAAW on this specific area, you are most welcome to further discussions. And this is my last second slide. So to conclude, WAAW will continue to support the implementation of the strategy on AMR and prudent use of antimicrobials in close collaboration with FAO, WHO, and UNEP, as well as the leading AMR institutions in Asia and the Pacific. I sent this slide to the very last because this is not directly about AMR, but still it could be an interesting project for you. WAAW HQ has a global project on establishing a reporting system for substandard and falsified veterinary products. I said it's not directly about AMR, but as you are all aware, quality diagnosis and appropriate treatments or disease prevention through vaccinations, these are critical first step to reduce the use of antimicrobials. So this project does contribute to our actions against AMR. We have 4 components under this project: to develop an alerting system for substandard or falsified veterinary products, and to develop guidelines on post-marketing surveillance. The third is to develop regional laboratory networks and to develop tools for field-level surveillance. We are still in a very early stage of this project and have just conducted our first pilot phase last year with 14 volunteered members to participate in this first component. And now we are expanding a bit to its second pilot phase, where we are trying to engage 40 more member countries in total. So if Fiji is interested in participating, this is the best timing to take the ride. So please feel free to contact me for more information. With this advertisement, I would like to close my presentation today. Once again, if you're interested in any of the WAAW's activities, please check our website or reach me out via emails here. Thank you very much for your attention. Bye.
Okay, that was Dr. Rahoko from the World Organization for Animal Health, and I'll ask Dr. Elva to relay our gratitude to her. The WAAW has been really supportive of the World Antimicrobial Awareness Week this year, and we're very grateful for the support that the organization has shown towards NARC. It's really encouraging to have one of the quadripartite members reach out to us directly. So thank you, World Organization for Animal Health. All right, so I think now we have something in chat. Okay, Dr. Joe is stop share. All right, stop share. Yeah. Dr. Joe is back as well, so I'll throw around some questions, and if any persons over Zoom has any questions, you can write them in chat or you can raise a hand. My first question is, I think I'll throw it to Dr. Joe first. Why is One Health essential when it comes to AMR? So, Dr. Joe.
Thanks, Reno. I hope my presentation helped with that. Yeah, so One Health is essential because AMR, or antibiotics, if we're just talking about antibiotics, are used in humans and animals fish and crops. And so resistance develops in all of these different populations. And that resistance can lead to treatments not working effectively, and that can lead to poor production in animals or plants. It can lead to animal welfare issues, and likewise in people, treatment problems and increased expenses and less effectiveness of treatment. So it's the same across all the species. And AMR doesn't really know boundaries. So there is movement across the species or the sectors, from that first slide that I showed, where there's flow off into the waterways, there's sewage, there's transmission that can go from animals to people, peoples to animals, people to crops, crops to people, and via waterways. And so it's it's what we call a wicked problem. It's got many different aspects to it. It affects many different people. It's quite challenging to understand the scale of the issue. A bit like climate change, it's challenging. It's not. AMR doesn't result in acute problems. It's, as they call it, the silent pandemic. So it's just gradually leading to poorer treatment outcomes, increased mortalities of people and animals, the same with some crops. So it's important that all of the sectors are resourced and included in an AMR program. Thanks.
Yeah, like as you said, AMR doesn't know any boundaries, eh? So it's like when antibiotics were discovered, it was sort of the silver bullet or the magic bullet that would cure everything, it seems. And our use has not been exactly judicious. And now it seems we're coming out of the golden age. Right? Dr. Elba, would you like to add something to this as well?
Yes, so thank you, Rinal. Yes, on the role of human and animal health in terms of like antibiotic resistance and contamination of the environment as well. Initially, we are just concerned about treating the disease, and then unknowingly, in treating the disease, we are creating a new condition in the environment and also in humans by exposing our environment with the antibiotics that may or may have not been used or overused, and then thrown into the environment, and then therefore exposing our animals and humans and communities through the creeks and rivers that are, like in Fiji, still very fresh and not yet polluted, and a lot of people access those natural environment. So yes, so unknowingly, in our focus in treating the diseases, we have created a new problem, which I guess this is an opportunity for us now to involve more our environmental department to come up with ways that is not restricting and yet instead benefiting everyone, all sectors.
Yes, I think you were saying like how Fiji doesn't have some of the diseases that plague our neighboring countries and regional countries. Yes. Like, would you like to elaborate?
Yes, so I think in one presentation earlier, it was mentioned that yes, Fiji doesn't have the ASF and FMD, which we are truly blessed in that aspect. And yes, so that sort of like help us have lesser exposure to, or our livestock industry to have lesser exposure to antibiotics to mitigate these diseases, or as a supportive treatment to these diseases. So yes, so we are truly blessed here in Fiji that we have less livestock diseases, and plus our first generation antibiotics like amoxicillin are still very effective in treating the general disease conditions in animals and livestock.
Would you attribute that to anything in particular, like maybe border control measures?
Yes, so we geographically, we are you know, we live in a paradise surrounded by a huge land, water mass. So making it difficult, or at least, you know, as a smaller country, we have smaller borders to control in terms of waterways. So I think that helped a lot. And then of course the challenge in bringing in live animals from other countries also helped a lot. Then it means we are focused on controlling or managing or monitoring livestock products.
But as COVID has shown that things
Yes.
can pass through borders.
Yes, that's right.
So the importance of infection prevention and control measures.
Yes, so definitely our country delegates, which is the Biosecurity Authority of Fiji, plays an important role here in Fiji in terms of like controlling not only livestock diseases, but of course also AMR. Yes, and of course COVID as well, like other human health diseases.
And does anybody have anything else to say? Aseli from WHO?
I think the panelists have explained it well, so
thank you.
No further comment.
Okay, I'll go on to my next question. What are some of the challenges of the One Health approach? Not sure who's going to start first. Okay.
Yes, yeah, so just to start off the discussion on that, in terms of livestock or animal health industry, I think we have been so used to be working on our silo, like animals are animals, but it is, I guess, that's one of the major challenges. And then in the Pacific, since avian influenza, there has been efforts from and regional support to break those barriers between the human health and animal health, and it's a process. It will come probably slower in the Pacific, but we'll get there. So yes.
And I heard somebody make this comment at the World One Health Congress. Even though we talk about One Health, ultimately it's all to do with human health. Like we are concerned about animal health in the context of how it affects us. We're concerned about the environment in the context of how it ultimately affects human health. So again, we are, as humans, we're still very siloed, right? We are used to thinking about ourselves.
Yes.
And less concerned about how, like, the environment will be perfectly fine without us.
Yeah, that's right.
Maybe even better.
Yes, they will allow time for recovery. Right?
Yes.
Yeah, but I guess in terms of breaking those barriers on the part of the livestock industry or animal health and production industry, it is important also to be proactive in terms of awareness, and then show interest in terms of continuously working with the human health and sharing that knowledge on how our knowledge on how we know that the livestock in terms of like production and and daily lives, how it affects the human. So yeah, so I guess the livestock industry or animal health and production industry also needs to step up and be more proactive.
Yes, Dr. Joe, I was quite surprised to see like One Health has been around for quite some time, maybe like a decade or more. Yeah, but it's like slowly catching on around here in the Pacific and Fiji. Dr. Joe, you've seen like a lot of challenges with One Health?
Yes, yeah, thanks, Renal. As you say, One Health has been around a long time. And it does feel like we're making progress at sort of snail's pace. And even when we have a global pandemic that involved, a virus that spread from animals to people, that raises some level of awareness, it provides some motivation to take a One Health perspective, but it's still predominantly words. And it's it's a challenging thing to implement. It involves so many changes and differences in how we've been doing things. It involves power sharing. It involves sharing resources. It involves taking time to understand the other person or world, you know, the animal health world or the human health world, and understand what's their reality and, you know, why are things the way they are for human health and animal health. So it involves changes of behavior and changes of attitude, and those sort of things only tend to come, you know, if we're in war, for example, and then you're really pushed to do it. And in peacetime, where it's sort of seen as optional, it's very hard to drive those changes. I guess in my experience that, you know, once you start working together, you know, with human health and in our One Health programs, we brought people from the human health sector in, you know, for teaching and capacity building and so on. And in our AMR programs in combat, in Fleming Fund, it's actually only by working together that you start to understand, oh gosh, you know, so people from the human health, you know, animal health, you experience the same sort of issues that we experience. Oh, you've got the same sort of approaches in epidemiology and analysis, the same sorts of techniques in the laboratory. So it needs to come, and I think it only comes through actually walking the walk together, and through that, and somehow you have to be forced together. And I think, you know, that's funding is a good way of doing that. And I know, you know, that is a driver. And the natural reality is that a lot of the funding at the moment, you know, predominantly comes for human health. But there's a recognition of One Health, and so there's some component of that brings in animal health, and that's frustratingly often very limited. But as you work together, then people become aware of actually the challenges, say, that animal health face, and grow in awareness. And I'd like to think that, you know, and gradually over time there's an awareness raising. I think definitely there's a greater awareness of bringing in the environment now in infectious disease and in AMR. And I sort of see that as really helping the whole One Health approach, because it's, you know, One Health's not just human health and animal health, but it's across the multiple sectors. And so it's about bringing about a change of thinking that actually it's not just our world that's important, it's other, you know, it's other people's worlds, the animal world, the plant world. That's important, and it's important for them in their own right. It's also important that they will affect humans, that, you know, food security is important. And so being affected directly helps raise awareness, but it's also important to yeah, identify that there are issues that parallel human welfare, animal welfare, plant welfare, I guess. So it's been frustratingly slow. It's just funding is an opportunity and a challenge. Government funding, you know, often there isn't, you know, there's funding for through the Ministry of Health for addressing human diseases or health issues, through animal health for diseases in animals, but there's a crack where there isn't the funding for the interventions that stop the spillover or say reduce the risk in animals that to people, or vice versa. You know, rabies is an example. Vaccinating dogs for rabies is a critical way of preventing rabies in people. But the Ministries of Agriculture are not funded to vaccinate dogs for rabies. Ministry of Health is funded for PEP, but not for vaccination. So where does the funding come from? So that's often the big challenge is for sustainability, is governments having a system that can fund the interface and the activities and the surveillance and the interventions that need to happen. And in the absence of that, you know, and donor funding can help that to set that up and get the relationships, get the data and so on going.
Yes, and then just to add to what Dr. Jo have, you know, been saying, like, yeah, it's a slow pace. And then in fact, One Health has been here for a while. Initially, it was known as One World, One Health, and then we also have the planetary health, and then I guess the more effective or better supported is the One World, One Health approach, which is has been lingering on. So the concept of planetary health, which technically involves the environment and the economy departments, is comes in and out. But yes, so through this the current One Health initiatives, we're slowly bringing in or involving environment, which is really good. Although again, it's as Dr. Joe have said, it's a slow process, but yeah, baby steps at a time, which is like really good. And then in fact, funding really is important. So, and then small pockets of projects such as the World AMR Week really helps to push the One Health initiatives forward as well, because it also like further adds justification that it's just not putting health and human animal health together. It's like different components, and it's an overarching concept that will be like overall like generally have different perspectives and different branches that will really benefit the people.
And interesting what you said, Dr. Joe, like how in the different silos similar systems develop. And is it possible that the solution from one sector can come from another sector, and then we're not really talking about, we're not really sharing that information?
Yes.
Like the very, very siloed approach that we have is that human health stays with human health and animal health stays.
Yeah.
And like we need this bridge.
Yes.
Like, and NAC is sort of acting like a bridge right now.
Exactly.
Yeah.
So good.
Yeah. The interesting, just to jump, the interesting thing is that it often makes it more fun.
Yes.
That when people from the different sectors realize, oh gosh, you're addressing the same issues as we are. Gee, you guys have got some interesting approaches that that would be useful for us. And all of a sudden, I guess, I mean, it's a bit of a cliche, but a problem shared is a problem halved. But that's not exact. But it's like if we can work together, you're learning new things about each other or others' worlds that we're a part of. I mean, we all eat animals and plants. We live in a world where there's farming and we live with pets. And so it actually becomes, it does become more interesting when there's an awareness and an understanding and a sharing of approaches.
Yeah, and talking about awareness, we are going through the third year of this pandemic, and it has really brought to the forefront the need for IPC measures. But how long will this awareness last? Like the world's attention span is very, very, very narrow and very short. And like, do you think like it'll go on, like the lessons that we are learning from this pandemic, or is it going to be forgotten by the next one?
Well, that's where our champions are plays an important role. So I guess if a country, as long as a country has a champion, or like have a committee like NARC, I think that kind of awareness or knowledge will linger on. But yes, so there's always needs to have those group of people that believes in the cause for it to continue.
You need those memory cells in place.
Yes.
Okay.
See, AMR is it's not a it's not an acute pandemic. It's there, and it's going to be there, and it's going to be there for a long time. So COVID comes. Well, it's come and it's not going to go either. But so AMR, it's the slow burn, and we've just got to over time work together more closely to address it.
Yeah, I guess you kind of answer my next question, which is a loaded question. Can the issue of AMR be stopped or solved? I think it seems like the answer to that is we're in it for the long haul. Like,
yes.
Unless there's some sort of magic cure, which like antibiotics were supposed to be, a next level magical cure, like it's going to continue. Like
So yeah, so I think Joe have answered that it's going to linger and stay on. I guess the word stop might be impossible, but it can be managed. Solve, yes, we can solve it by managing it, I guess.
Yeah, I think it's important to see that we can make an impact. You know, so we can actually through antimicrobial stewardship reduce levels of resistance. I mean, you know, we have a problem. You know, once there are resistance genes circulating in the population, you can't get those genes out. But we can reduce the levels of resistance. Hospital-acquired infections, you can actually reduce the incidence of hospital-acquired infections. Levels of resistance in animals can be reduced by reducing or changing antimicrobials. Levels in the environment can be changed. So it is possible to reduce. So I think that's important. We're not trying to do something that's impossible. There are examples of success, and so that's the encouraging thing.
Yes.
And again, it's you know, it's baby steps. It's setting an objective. It's putting a plan in place, and monitoring that. You know, to see, and that's where sort of surveillance is important. Surveillance is a way of understanding the problem, and then also monitoring changes over time. So yes, I think it is possible to change it, and we need. But we need to do something. We need to implement the programs, but we also need to have systems in place to monitor that we are making a difference.
Monitoring, yeah. To think that we'd be probably in a worse off place if we didn't do anything at all. If there were not any interventions in place, any stewardship in place, any monitoring in place, then we'd probably end up in a much worse situation that we are currently in. I'll see if Aseli has anything to say, or see if Walter's also online.
Well, this is related to the
the
question?
The question, yeah.
Yeah.
Okay.
So I just wanted to say, just adding on to what Joe has said, as well as Elva, is that we just need to understand that AMR is a natural process. It's an evolutionary process, so it's going to be there for as long as the world basically is still in existence, because it's a natural process.
Yes, the other thing, yeah, as Walter said, to understand, like, it is basic evolution.
Yep.
Like, this is the natural progression of things. If you introduce an environmental obstacle, living things will find a way around that obstacle. Like, it's the same as how we overcome challenges. So antibiotics is a challenge, or antimicrobials are a challenge for the microbials, and they will overcome it, but it's up to us to stay a step ahead of them. Yeah. Okay. I'll go on to my next question. With AMR being a global threat, what measures can health professionals and the general public apply to help mitigate this threat? Would you like to start, Dr. Amar?
Yes, so I guess as professionally, it is important for us professionals to always practice our ethics. We didn't discuss it in university for nothing. It is there for a purpose. So let it be, as educated people, may it start with us in terms of like the proper use of antibiotics. And of course, in the public, educating the public as well is very important. Making them understand the basic principles of using, and then the how antibiotics work. And I guess the basic important thing there is that for them to understand that one tablet will not cure everything. It needs to be a whole protocol that needs to be completed. So yeah.
And also, not only the public, but also at home.
Yes.
Like, we have to start with our own family and ourselves. Like, are we following the right protocol? Yeah. Anybody else would like to add on to this? Like, what can health professionals and the general public do to help mitigate the threat?
Yeah, so I mean, I guess personal responsibility is the key, but it's also giving people the knowledge and the tools, you know, sort of so that there's an awareness of the problem, and then, you know, what can be done about it, and showing success is sort of so there's a motivation to keep doing it. I mean, and it is a global problem, so we can learn from each other as well in different countries and different ways of doing things, of sharing data. I mean, there is global spread of resistance genes, which has, you know, exacerbated the problem. So it's important that all countries are doing surveillance, putting in place measures, and learning from each other.
Yeah, so again, basic IPC measures goes a long way. Like with COVID, vaccinations were like the key to controlling spread. So I think with AMR, like keeping healthy, getting your vaccine preventable diseases in check, hand hygiene, food hygiene, yeah, all those kind of things.
And like, yeah, as you mentioned, like just to add on vaccination, again, one dose is not enough. If it needs a booster, then you might as well just follow through with the booster, so that in the first place, you won't need the antibiotics anyway.
Yeah, there's a new strain of COVID in Singapore.
Okay. Interesting.
Yes. Okay. I'll go on to my next question. Okay. This one is probably for other things for the environment. I'm not sure if anybody is here from the environment sector, but often neglected aspect of One Health is the environment. What role does the environment play in the overall fight against AMR? Not sure if anybody from the environment sector is online, but I'll maybe ask Dr. Joe to elaborate. Sean?
Is there anyone online before I say something?
Nobody that I recognize from the environment sector. No.
So that's a good question, a big question. So the environment can play a role in a number of ways. There's some evidence that there's actual resistance. Environmental organisms can produce resistance genes when they're under pressure from antimicrobials that are in the environment, or you have other resistance bacteria going into the environment. There's pressure on bacteria, environmental bacteria, to produce resistance. So it can contribute to the problem by producing resistance genes. The actual contribution is really difficult to quantify and understand, other than to know that it is. It can act as a transmission pathway very clearly, you know, through contaminated water. So our whole environment ecosystems are connected, and AMR resistant bacteria and genes flow throughout the whole environment, and it's an important source of transmission of resistance between populations and between individuals within populations. And then as a tool for so there's I guess looking at interventions that might reduce those transmissions. So there's WASH, and there's other programs around reducing the release of antimicrobials, and also resistant genes and bacteria into the environment through sewage treatment, through better management of waste and that sort of thing. And then there's also use of the environment as a way of telling us what levels of resistance are happening or there are in a population. So it can be it's pooling samples, if you like, from a lot of people or a lot of people and animals and a lot of, so as I was saying in my presentation earlier, that there's interest now in looking at hospital sewage and understanding resistance genes that are in the hospital sewage as a way of as a better and more sensitive indicator of resistance that's happening in the hospitals, compared with culturing and doing AST on bacteria that have been cultured from individuals. So it's increasingly now being, as more knowledge and the tools become available, as a surveillance tool for understanding resistance in populations, and then as a sentinel, and then once those are identified, then looking at programs that can be put in place to reduce it. And likewise off farms or off through aquaculture or through crops. Looking at, I mean, in those cases, it's quite difficult if you're using rivers and things. It's difficult to get at source attribution because there's lots of things coming into the river. But it also can be used as a monitoring tool over time to see if there's increases and decreases following interventions.
Thank you. I think Alex Walter I think the AMR project is doing something about monitoring of AMR genes.
Yes, that's correct. Yeah, because again, as you're all aware, that the environment is quite an important sort of sector, because you really need to. I mean, it gives you a platform, a really good platform for understanding the microbial ecology, in trying to understand how the resistance it's occurring, and that's why we have a small sort of sub project looking at the AMR genes in the environment across a wide variety of samples, so to understand what type of genes you've got, and also understand some of the AMR hotspots, because some of those genes can be clustered within a certain region or within just a particular type of samples. And then, and again, the reason why we're doing that, the third reason we're doing that is to Joe has mentioned it, the early warning system. Because when you start seeing the emergence of particular AMR genes in the environment, it can help you to ask the question, perhaps, where this thing is coming from. For example, we're not going to say particularly, it's coming from here, but it gives you, through using statistics on top of that, it can give you an overview of maybe of where the AMR genes are coming from, and then also to alert the hospitals to be aware of certain genes that are seeing in the environment that can be coming to the hospital, in a period of time. So it's a really valuable tool, to have. I mean, the environmental gene surveillance is a very valuable tool, but it's quite expensive as well, as you all know, and that's why we are trying also to work out some sort of technologies around environmental surveillance, like really sort of cheap surveillance tools that can be applied in the environment. It's something that you're thinking hard on. It's not easy, but it's you've made a first attempt to developing some technologies that could be widely used in the environment, particularly to showcase the type of genes that are in the environment in an affordable way, because that's what perhaps will be much valuable for Fiji, because they can't afford this expensive sort of genetic tools.
Dr. Walter, are these samples, the surveillance samples, purely just environmental samples, or also biological samples like filter feeders and whatnot you guys are using?
Yes, I think the mostly environmental samples, including the mollusks, the kai, because that's a really good indicator of the health of the environment. And then what you're trying to do is not just look at the environmental samples in isolation, but also compare them with the animal health samples and the human health samples. If you're seeing sort of a pattern of resistance genes across those three sectors. So yes, it's environmental samples, but we are also analyzing human health samples as well as the animal health samples to see patterns. And I was told, I'm not a geneticist by any means, but I was told that it's really important to understand the phylogenetic tree, some tree, phylogenetic tree of those samples you're seeing. Because then you're trying to quantify, for example, for Fiji, what are the common sort of types of genes that you're seeing in a phylogenetic type of way. Because, remember going to collecting, you have like 5,000, I think, isolates at the moment. It's a huge sample size. So what do you do with that information? How do you utilize that information? So that's why you're looking at just, again, the phylogenetic type of work that will tell us a pattern, like a group of bacteria that are quite common. Yeah, and before I forget, another key thing about the environment is the emerging pathogens. Like we're trying, that's what in Fiji, we are looking at that as well. Like you're seeing some sort of emerging pathogens that could be important in human health that are emerging in the environment. It's another important aspect as well.
I had the chance to meet with the Singapore Food Agency a week ago, and they were talking about surveilling sewage complaints, because Singapore is such a global hub. They want, and once this sewage leaves your body, is no longer your property, they can go ahead and sample the sewage that are coming out of the planes and monitor if there's some sort of global resistance or global pathogens that are floating around, which is very interesting. And I'm not sure if any monitoring is done at our local sewage plants for AMR genes or anything like that, but it'll be an interesting avenue.
Yes, absolutely.
Yeah. Okay.
Yeah, sorry, Reno. Just letting you know that we are doing that with the USP wastewater treatment plants.
Right.
Yeah.
I think Dr. Vincent mentioned that on Friday. Okay. I have one last question, and this one I guess I'll direct it to Dr. Elva here. A controversial subject is the use of antibiotics in animal feeds. So this is a three-part question. Why is it used? Is it a concern for AMR? And what can be done to reduce the use? So why is it used to begin with?
Why is it used? The principle of prophylaxis, so preventing the disease or illness before it even attacks the livestock. Because of course, especially in commercial operations, we want all our animals to be healthy. So even before it starts to show sign, and which causes weight loss, and of course, that means more cost in making the animals fat again, we prevent it from the start. So that principle has been used for over decades or centuries already. But again, because those antibiotics are previously like newly introduced in the market, so it works on a lot of wide range of pathogens. So, and then as we continue to use it in feeds, it did produce good outcomes and good weight for our livestock. But again, eventually it starts to not work. So new antibiotics were developed and used and then added into feeds to overcome those, we call it resistance as well, even before. And eventually we don't use only one antibiotic, but multiple antibiotics, because also of the side effects that like the side effects of antibiotics. Some antibiotics causes weight gain, good muscle mass. So not only are we using the antibiotics to prevent the pathogens from infecting or making the animal sick, but also with the side effects of like having more, gaining more body weight. So then, yeah, as we go along and then more awareness, and then after centuries of using or decades of using it, now there are now pathogens that, when there are farms that are, having outbreaks, and then the usual antibiotics that veterinarians know that works no longer works. And then that's probably one of the main, cause of or main motivation to have more awareness on AMR. Now the second question there is there a concern for, yes, of course, as mentioned, that can also the waste from the animals, any excess antibiotic in the body that's not utilized, especially by healthy animals that we're providing the antibiotic to, can be flushed out in the system and then down to the sewage, which also contaminates our environment, and then can access natural waterways like rivers and all. Therefore, those subsistence farmers whose animals drinks in the rivers as well, or those who still use the waterways, the rivers to bath or to wash their laundry or cook before. So of course, that's how the antibiotics spread in the environment. Now, and what can be done to reduce the use? Very basic, improve our, observe basic good farm hygiene, biosafety and biosecurity. Generally, that's the answer. So in Fiji, in addition to the geographic barriers, in country, as long as we observe proper and good farm biosecurity practices, ultimately we can reduce the cost in terms of like reduce the use of antibiotics, and then therefore also reduce the cost of production. Yes, and then we have there Dr. Walter as well, who's also a veterinarian. Yeah, Walter, you have anything to add on that?
No, not really. I think you mentioned, you've basically explained reasons why they're being used. We use antimicrobials in the animal health sector. But again, it's just, as you rightly say, it's the issue of promoting animal husbandry to reduce the need for prophylactic use. That's the message.
So my question also is, does free range help? Like, is it better?
In terms of animal welfare, yes, of course. They are also creatures that feel. No one wants to be caged. Again, but the free ranging is also case to case. So we're now in the modern world. So if you're a farmer and then you're free ranging, but it also disrupts the community, it's not healthy. So I guess there always needs to be a balance. And again, our practices, depending on where we are situated, we learn to adapt to the community or to our environment as well. So, yeah.
I think Dr. Joe wants to say something.
Thanks, Renal. Yeah, so a couple of things. And I know there's an issue around, low-level use of antibiotics in feed for animals, but I just actually wanted to note that antibiotics are being used in this way in people as well, which is actually, a serious issue. So it's not just in animals, and I'm not saying it's not a problem in animals, but I'm just wanting to reflect that it is. Antibiotics are used in this sort of way, prophylactic way, in people. So doxycycline for vector-borne disease, it's just escaping my mind. Azithromycin is used, and actually in the early days in the 60s, when everybody sort of fell in love with this wonderful thing called antibiotics, they were used as growth promotants in children to actually improve health of children. So I guess it's the scale in animals is much more widespread, but it is an issue in humans. And in animals, I think it's important to, if we're looking at how to address it, it's really important to look at the different, the context within which they're being used. So if you look at smallholders, subsistent farmers, they and they can get access to antibiotics and they're quite cheap. They might be using them even though they might know they're not actually that effective, but it's like an insurance for them, because if their animals die, then that's their, they've lost their livelihood. So, to actually change behaviour in that group, it's really important that, it's understood why they use, how they use, and what's a viable alternative. Is it putting, is it building trust with local, government sort of extension workers, or industry provides extension workers that can actually provide the smallholders with an alternative. So it's driven by their fear, their economic viability, I guess. So that needs to be addressed. Then you might have, really high intensive production systems. It's first of all, you need to know what's the level of the problem, and it's often quite difficult to get that information. So high biosecurity systems, I guess we assume that they're not using, they don't need to use antibiotics to encourage growth and production, but maybe that's not the case. And then there's a sort of a middle tier of semi-commercial producers that have poorer biosecurity, and they are widely using antibiotics to support growth of their birds. And then looking at the interventions and the policies and the legislation, what do you do to actually address this this use of antibiotics, which is actually contributing to resistance both within pathogens in animals, and there are a number of cases where it's actually spread to people. The avapacin used in poultry and pigs and spread to vancomycin resistance in people. So now avapacin's banned, looking at colistin and the risk of the colistin resistance gene spreading. So you put in legislation to ban growth promoters, and all of a sudden prophylactic use of antibiotics goes up really quite dramatically. So it's just shifting. It's not actually solving the problem. So it needs careful consideration in how you address it. I mean, WAAW's program of collecting and supporting countries to provide data on their antimicrobial use is a good starting point, and that's gradually raising awareness of what's used in countries, and start to benchmark and looking at reducing antimicrobials for growth promotion, for prophylaxis, and for treatment, and then building on that to have stewardship programs with farmers, with veterinarians. Just providing a bit more, I guess, on what can we do about it. It's very important that it's not, just putting legislation in place isn't going to make the problem go away. It just shifts it. You ban feed providers, feed mixers from mixing antibiotics with their feed. Well, then farmers start to mix it themselves, and then it's often worse because the antibiotics might not be mixed evenly, and you get underdosing, overdosing. So it's the approaches to this need to. That's where One Health, multidisciplinary, social science, to understand why the antibiotics are used, economics, and then looking at designing programs that are actually going to create the outcome that we want. Over.
Yeah, so that's an important point there. So designing programs that, to get the outcome that we want. So because a project in Asia might not be really applicable to, the Pacific. So I guess even in, we say animal husbandry to prevent to reduce the use of antibiotic in feeds. Yeah, so the program might need to be different from Fiji and Vanuatu, because the practices are also, and the issues are also different. So in terms of like Fiji, I guess it's important to also understand, or at least have a baseline information whether there's really residues in our meat, because as far in terms of animal health industry, or as a veterinarian, we know that we have not been dispensing too much antibiotics in farms and in livestock, but we're not sure whether there's other pathways that the commercial poultry have, or commercial piggery have, that they can bring in those antibiotics in feeds or in other forms. So for us to be able to, explore whether there's really a risk in Fiji's, have antibiotic residue testing in our meat. So it would be good,
So is this commonly not done?
No facility in like that test is not done in the animal health sector yet. So I'm not sure about the human health, but meat testing for meat residues in livestock products is not done.
So I've seen like some chicken that says hormone-free and antibiotic-free.
Yeah, so basically maybe
claim.
yes. Yeah, so whether that's a good thing to validate, really,
Yes.
so that the Ministry of Health and the Ministry of Agriculture can really support or endorse those claims by the local producers. So, and in fact, it's a good thing, if they get endorsement from both Ministry of Health and Ministry of Agriculture, that'll also be a good marketing for them.
Oh.
So yeah, so while Reno is busy.
Labeling, the labeling of the feeds in different languages.
Oh yeah, labeling of feed
Labeling of feeds
in different
different languages.
Yeah,
How you entertain them?
The labeling of
Because
feeds.
available.
I guess in Fiji it's not much of a problem in terms of like feeds, because most of we have the Pacific feeds here in Fiji, which is mixed here, and a lot of the manufacturer aims to use local products as possible, and then just imports other components of the feed. We're lucky here in Fiji because everyone understands English. Maybe in other countries that can be an issue, because there's like maybe in the Philippines can be an issue. Yes, so in that case, the suppliers really have to translate it somehow, or give the instructions both in English or in the local language. But yes, in general in Fiji we don't have that problem. So our problem is not really a problem, but it might help to have like a closer monitoring in terms of like really if the components in the feeds is really reflects in the ingredients list, and whether there's really no antibiotics on it. So yeah. So I guess that's a more important issue for to look at in Fiji.
Yeah, I think there were some cases where the antibiotics were not listed in the feeds, but it somehow there still.
It's still there. And then see in countries like Fiji as well, it's easy to, people know each other very well, like, everyone knows each other. So it's easy to ask, someone from the company to say, oh, just add in here, that's not reflected.
Yeah.
But we haven't come across that issue yet. Again, we're not monitoring that close, and in terms of in general in the livestock industry, we have not encountered much resistance. Again, even the amoxicillin still works as long as given properly. Most of the complaints that we get from farmers that indicates that the antibiotics not working, closer investigation revealed that they have not been consistently giving it as instructed. So that's why, of course, if you don't give the antibiotics properly in a way that, on the right dose, on the right time, then obviously it's not going to work. So, yeah.
So I guess that's an avenue for education for the farmers?
Yes, and then that's where we're really focusing at, because, again, we want to preserve, the antibiotic use in Fiji to be like even the first generation medications still work. So because it saves the farmers a lot of money, and of course, in terms of community health, it's good that we're still on those basic antibiotics still work.
An interesting thing I just like to add on is the emergence of laboratory-grown meat.
Right. Yeah. Luckily, we're not. Luckily, I hope we're not expecting to have access to those meat anytime soon. Let the world access those.
It's available in certain countries like Singapore, one, and there's certain restaurants where you can get.
Oh, really?
Yeah, those sort of. But interesting from a point that I assume it does not need antibiotics to grow.
Yes. Yes. It does not. Yeah. But whether how do they develop the lab meat itself is is something that we want to learn first before we start eating it. And I guess in Fiji too, even if it becomes available, our the community prefers like real meat, fresh meat,
organic.
Yes.
What do you call this? It will take a long time to trickle down here, and it's very, very prohibitively expensive. Like up to 10 times the cost of actual like farm-grown meat or something. But maybe it's like if all the safety checks and all the testing is done, maybe it's a way forward. Like to leave our animal friends alone.
Yes, maybe. Yeah, but I think at this time, our Fijian community still prefers to, would opt for the bush meat.
Yeah.
Compared to the lab meat.
Actually, well, depending on how clean the environment is, the wild animals might be much more better off consuming those.
Yes, and then of course they're with AMR too, they're at risk if we don't, if we contaminate our environment with the antibiotics. Like I think Shona have presented in one of her slides that the both animal health and human health facility may be contributing to contaminating the environment through the landfill, through the disposal of the expired drugs in the absence of the incinerators on both side of the industry. So so again, the professional disposal of the antibiotics, both on the human health and animal health facilities, and that's of the government, is important issue that needs to be addressed and continuously monitored here in Fiji.
Yeah. So if the environment is contaminated, even our wildlife is
yes, that's safe. Where our bush pigs are at risk. Yes. Our bush meats are.
It's Christmas coming up.
Yes, that's right.
So very, very interesting.
Yep.
It's also the way these genes are shared so readily amongst, and it is cross species. Like a gene from this particular bacterium can get transferred to another species very easily.
Yes, because like a lot of there's still a lot of rivers that are being used for livestock production in Fiji. Yeah, so especially on cattle farming, there's huge lands for grazing that have riverbanks that where our livestock have access, and then of course rivers are flowing from one village to another. So livestock here can a commercial farm with cattle, a commercial cattle farm who's providing antibiotics at a higher range, maybe contaminating the river, and then the water flows down the stream towards a village with cattle who have access to these rivers as well. So those kind of things. I'm not saying that we have that in Fiji. I think still, because our antibiotics use in livestock is very low and pretty straightforward, but it doesn't mean that it cannot happen in the future. So so at this point, it's good to continue awareness on that aspect.
So there's a lot of need for awareness and education, surveillance.
Yes.
Yes, and
then the AMR project on environment was I think really helpful. That's a pilot, and then and it's something that can be regularly done to even after the project. So yeah.
Well, so I have run out of questions. Unless you have any questions,
No, I have
the
no
panel
questions.
has any questions any comments? So, anybody from the audience?
Like comments on direct access to retail pharmacy.
Okay.
There's a comment here from Gina on the comments or perspective on farmers having direct access to antibiotics through pharmacies. Well, the initial, when it was initially brought out of the table, we are, as veterinarians, we are quite concerned about it. We are very concerned about it because if farmers can easily ask the pharmacist to dispense them antibiotics for their livestock, then that can be, that can be out of hand. Like, even if it's recommended, if the farmer feels that it's a magic wand, that buying the antibiotic is like a magic wand that they can easily buy from from pharmacies, then that can result to high antibiotic load both in the animals and in the environment. But luckily, when that discussion progressed, our pharmacists have good understanding of antibiotic use, and they acknowledge their responsibility and capacity to dispense the medication. So with them as a professional industry, they also want to put a boundary on what they can and can dispense. So that sort of like gives us veterinarians a peace of mind that that even if there is demand or pressure from the farming community to make these drugs available in the pharmacy, that there's still hope for these antibiotics to be controlled in terms of livestock use. So as long as we continue that partnership, and then as long as we continue to talk, I guess, even if there's a pressure from higher up to have those medications available in the pharmacies, we'll still be able to manage and to avoid it getting out of hand.
Yeah, so I guess the same rules should apply to both sides. Like,
yes.
Prescription from a veterinarian is required.
Yes, that's important.
Do you have a list of doctors that like submitted to the pharmacies? And okay, these are the veterinarians existing in Fiji.
I think I am not probably not the best person to answer that. So, but as a veterinarian, I have not been advised of any list to be involved in any of that list. Although the Ministry of Agriculture and Biosecurity Authority of Fiji have been constantly in communication with the appropriate ministers and permanent secretaries on that. So I'm sure there are only very few veterinarians. So I guess, it's so easy to come up with that list and then advise the farmers and share that information with the pharmacy community. Yep.
Thank you.
Okay. So I think we're coming up to the end of this.
There's one question.
Okay, hold on. Let me just expand the chat. It's from Sipa. Do you think any of the municipal solution? Okay, so there's a question from Shilpa in the chat. Do you think that the way government hospitals have restricted antibiotics to avoid misuse, should private hospitals have same procedure or protocol, or should they adopt one? Yeah, I think so.
They should have.
The thing is, there's no point in having restricted antimicrobials in only one sector. I mean, it has to be like because of the nature of AMR.
You cannot have double standards.
Yes, I mean, it's important.
We don't know what their protocol, but like government have protocol.
I think maybe it's a. It should be a work in progress that we push for adoption of these particular protocols across all sectors.
And I guess
management.
I think the human medical community has an active CPD sessions or regular professional body meeting, which is a good avenue to promote this kind of to lobby this kind of matters. And I would think to, of course, as we mentioned earlier, professional ethics. Huh? So we can. I think it is safe to assume that they understand each other, and then they have across the board would have initiative, like the private hospitals would have the initiative to implement something that they feel that is really important. That is the programs that are policies that are being applied in government hospitals. I would assume that they have that understanding. If it's important, they should be applying it in private hospitals as well. We can only assume.
Again, the thing with stewardship is that the recognition of our shared responsibility.
Yes.
Ethical responsibility to humanity. It's not like this is not something that we can play around with. I mean, like the hospital-based restricted antibiotic system exists to safeguard the patients, prevent resistance in the first place, and it should be practiced across all private sector and public sector as well. So I think we can all agree on that.
Yes.
All right.
Yes, good. Thank you very much. Thank you for this opportunity to.
I think there's some good discussions going on. We'll have the opportunity to further discuss on Thursday.
Yes, on Thursday.
It's been a great collaboration with WAAW this time.
Thank you.
All right. Thank you so much, everybody, for staying with us for this past 3 hours or so. Unless there's any further questions, thank you to all the speakers, WHO, WAAW, and Combat AMR and EMA, all these projects and organizations that have contributed towards this webinar, and thank you to the audience as well. Right? All good?
Yes. Thank you very much.
See you next time.
Yes, see you next time.
Bye.